It's Dr. Cassidy here, and I'm going to go over some cardiac concepts that are really important to understand. If you take your time, go through this slideshow, and I recommend that you kind of stop at each slide, learn that slide before moving on to the next because they build off each other. And if you can have an understanding of these and memorize the medications, that'll really help you. And I think you have six cardiac specific topics over the next 2 semesters that if you have this foundations will be so much easier for you to grasp those because they're really just building on these, as well as I think at least four others that include perfusions. Now, and the medications and the symptoms, of course, that are going to be across multiple topics that you'll be learning about. If you have a grasp on these, you will have a basic understanding of what's going on with a lot of the medications. Okay, so the first slide is just the movement of blood through the heart. So it comes into the right atria, goes to the right ventricle, goes out into the lungs where gas exchange occurs, comes back into the left atria, and then into the left ventricles, and out the aorta to the body. That is the basic flow of blood. And this is the anatomy of the heart. And I've added in the valves here, and I do encourage you to memorize this anatomy, memorize the flow of blood. So again, blood comes in from the superior and inferior vena cavas into the right atrium, and then it goes through the tricuspid valve into the right ventricle, and from the right ventricle, it goes out the pulmonic valves to the pulmonary into the lungs, and there's where gas exchange occurs. Then they come back in the pulmonary veins into the left atria. From the left atria, it goes through the mitral valve into the left ventricle, and then out the aortic valve to the aorta to the body. So really the valves, the pulmonary valve obviously goes to the lungs, the aortic valve obviously goes to the aorta in the body. So I think those will probably be easier to remember, but just thrown in there that the tricuspid valve is on the right between the atria and the ventricle, and the mitral valve is on the left between the atria and the ventricle. And if you can memorize all of this, it'll help you in understanding a lot of function within the topics we'll be covering. Okay, this is the electrical activity of the heart. So you know the electrical impulse begins in the sinus atrial node, and that is the initial thing when it occurs is that you'll have this little P wave. This is what you would see on the EKG strip or on a telemetry. This is the electrical activity, and down below is going to be the physical activity, what the muscle is actually doing, that the electrical activity is making the muscle do. So this little blip here, the first thing you see is called the P wave, and that is the atria contracting. We've got this little electrical impulse, and it makes the atria contract. And then you can see right here, the QRS, much bigger, much stronger electrical activity to get those ventricles to contract, which are bigger. That this is your ventricular systole. That is when the ventricles are contracting, and it's at the AV node. Goes from the SA node to the AV node. Okay, now within here, at the same time that the ventricles start to contract, the atria relax, and you're in atrial diastole. And then over here, this little T wave is the ventricles relaxing. So when you have an electrical current started in your cell, right? It first it's called depolarization, and that causes the muscle to contract. That is the excitatory part of it that makes it work. Now then it needs to relax before it can do another impulse, right? So if you think of it like in terms like if you jump up in the air, you can jump up, but then you have to come back down before you can jump again. So you have to relax before you can jump. The same is true of this electrical activity. It depolarizes, making the muscle contract, but then it needs to repolarize, to relax before it can do it again. And that's what this T wave is. Now, the atria also repolarizes, but is buried in the QRS. You don't see it on this strip, and you don't have to worry about it. But the T wave is just that. It is the ventricles relaxing. So then you have this point here where the atrial and the ventricle are both relaxing, right? When you listen to your heart rate, you hear doop doop, and then a pause. And this is one cardiac cycle. Okay, now I have the electrical activity here, the PQRST, along with the the physical movements and the blood movement in the heart, just to give you a visual of it all working together. So here, P wave, your atria contracting. QRS, the atria are now relaxing, and your ventricles are, the valves are closed here, the ventricles begin to contract, and then they relax. And everything is in diastole here, and this is one cardiac cycle. When it comes back, everything is repolarized, relaxed, and it starts again. Okay, so the coronary arteries, that's these, and you certainly don't have to learn the anatomies of these or the names of these, but they're simply the arteries that supply oxygen and nutrients to your heart muscle, which it needs, and it gives it to the atria, the ventricle, and to the conduction system, the SA and the AV nodes. So it's bringing this. So when you have coronary artery disease, when you have a stiffening or thinning of those, or you have plaque in there that makes them thinner, then you have less oxygen getting to this heart muscle. So what's important to, the point I want to make here is when we talk about increased workload. So certainly if you're running, right, you're going to have increased workload of your heart because your heart needs more, is working harder to get that blood going, moving. So if your arteries are obstructed a little bit, then you're going to feel chest pain. So when you're feeling, and then if they get more obstructed, you would feel that at rest. And if they're completely blocked, that is a heart attack. So what's important to understand here about the workload is that it's not just running. Like if you have increased blood pressure that your heart has to pump against, that is also increased workload. Or if you have like hormones that are being released that are making your heart workload increase, then it does need more oxygen. Okay, cardiac output is just simply the amount of blood that your heart puts out. So we talk about cardiac output, and we say if it's if it's decreased, that's a problem because you need perfusion, you need oxygen and nutrients and all of the things to get to your organs. And if you have decreased cardiac output, that can be a problem. So exactly what it is, it's technically it's the amount of blood that your ventricle puts out in 1 minute. But you don't have to remember that specifically, just at the concept of cardiac output. And this is the formula here. But stroke volume is the amount of volume that comes out with every contraction, right? So we can contract, we can control how much fluid is coming out, and we can control your heart rate with medication. So can you think of a medication that would control how much fluid? Maybe like a diuretic, furosemide. If we give you a diuretic, you have less fluid. So if you have too much fluid, we give you less, and you're going to have decreased cardiac output because if you have heart failure, you have too much, right? Now, if you didn't have enough fluid, we could give you IV fluids, and that would increase your cardiac output. Because this is increasing the stroke volume, right? So for the heart rate, of course, we can give you meds to make your heart rate higher or lower, because if your heart rate is like 30, you're really going to have low cardiac output. It's not going to be putting enough blood out over a minute to sustain life, not at 30. So there's meds that we can give or things we can do to increase your heart rate as well. Okay, so blood pressure. Normal blood pressure is 90/60 and 120/80. 90/60 is a normal blood pressure. The other thing that we look at is so that is your diastolic blood pressure is the lowest, like, what's left when you're not contracting, and the systolic is, the most pressure when your heart's contracting. That's the most pressure that it's putting. The mean arterial pressure is the average of those two. It's the average, I shouldn't say it's not the average of those two, but it's the average pressure that is within your arterial system. And that's the mean arterial pressure. We also call it MAP. A normal MAP is 70 to 100. If it's over 100, that's not so bad. But if it is lower than 60, that means that your organs are not getting enough oxygen to sustain life. So lower than 60 is not good. Lower 60 to 70, also not normal. But once you're below 60, you're really not perfused. So to calculate the MAP, you are going to do your systolic blood pressure plus two of your diastolic blood pressures, and all divided by 3. So if my blood pressure was 110/70, the math would be 110 plus 2 times 70 divided by 3, and my map would be 83, and that is a normal map. So this is how you calculate it. I don't remember if you know how to calculate it, but I think it's probably important to memorize this. I don't know if we test on it, but you definitely want to know that a normal is 70 to 100 and less than 60 is not life-sustaining. Okay, so vascular resistance. So what's going on in your veins and arteries? So this is like a normal one. Here's the muscle. Here's the blood flowing through it. Normal blood pressure, normal amount of fluid. Everything is perfect. Over here on the left, you can see this muscle has contracted. And it's just like if you make a muscle with your arm, your muscle gets bigger. If your muscle contracts, your smooth muscle around your arteries and veins contract, they get bigger and they constrict the artery or the vein. So this could cause like blood pressure. So you can see that it's much smaller and there's everything's going to move more quickly and with more force because there's less area. Vasodilation, on the other hand, is where the muscle is really relaxed. Your vein has gotten bigger now, or artery has gotten bigger now, and the fluid is moving slower and not getting to the heart as much. So this would decrease your cardiac output because it's going much slower. And this would increase it unless it was like your artery right on the other side and you had to press against it. That could be a problem. That's your blood pressure, right? So smooth muscle relaxation makes blood flow more slowly and less forcefully. So I wanted you to see this because we can affect these. So if we have, vasoconstriction, if we have really high blood pressure, then we can affect the smooth muscle to cause dilation to get it back to normal. So I don't know if you can think of a medication that would do this, but I'll give you a second. Here we go. So calcium, like a calcium channel blocker, is going to block calcium. You need calcium to do muscle contraction. That's causing the muscles to move. You need calcium. If we block it, if you don't have calcium, they won't be able to contract, so they won't be able to do this. They won't be able to constrict. And there's direct vasodilators and other things too that can really kind of make these dilate. Okay, preload and afterload. Preload is just the fluid that's come back. You can just think of it in terms of fluid, the amount of fluid that comes back to your right atria, that's brought back to your heart. And this can be affected if you are really dehydrated or if you're bleeding out, you're going to have decreased preload. So you're going to have decreased cardiac output. And we can give you more cardiac output by giving you IV fluids, right? Afterload is the pressure. So it's how much pressure that your left ventricle has to contract against to get that blood out. So you can think of this in terms of blood pressure. And if we have increased pressure here, then we can have decreased cardiac output because your left ventricle isn't going to be able to at some point get enough blood out because it's getting that blocked out. So we'd have decreased. So we want to lower the blood pressure to increase the afterload. And also this again, having increased afterload, if I'm having to work harder to get it out, is increasing the workload of the heart. So you need more oxygen to get to your heart muscle to have it sustained during those increased workloads. And contractility is just the force, and it's also called inotropy. And I want you to remember that inotropy is contractility because we have medications that are positive inotropies that can make your heart beat with more force, so more efficiently when needed, or negative inotropy that can make it beat with less force. So if your workload is too hard and we want to decrease your workload, we'll give you a negative inotropic medication. Factors within our body that affect this beyond medications are the activation of the sympathetic nervous system, release of hormones, epinephrine. So epinephrine is adrenaline, right? So if you take epinephrine, then you're going to get a faster heartbeat, higher blood pressure, and increased contractility. So everything's going to be working harder to increase your cardiac output. And I like this slide. It's from NurseShip. It just it puts the three together and really shows what's going on. So here's our venous return. Here's our preload. here, right here is the afterload, how much the work has to, how much the left ventricle has to push against to get the blood out into the aorta. And here's the contractility, just the workload of the heart. Okay, so things that when you have decreased cardiac output, we do have compensatory measures. So one of them is RAS, the renin-angiotensin aldosterone system. So this is your kidney saying, oh, I don't have enough oxygen, there's not enough perfusion here. So it activates RAS, and that does two things. It increases your blood pressure, and it, because it vasoconstricts, and it keeps more fluid. So it doesn't let you put as much water out in your urine. So it's going to keep your preload, and it's going to vasoconstrict all of this to try to increase cardiac output. So it's getting more perfusion to itself. The other thing that does is your sympathetic nervous system, when receptors notice low perfusion in them, and you have these in your carotid and on your aortic arch, they're like, oh, there's again not enough perfusion. There's not enough oxygen going across these receptors. They are going to release epinephrine, and that is going to increase your heart rate and contractility. And that is just to get increased cardiac output. And we use medications to mimic or block these as well. Okay, this is a normal on the heart, just a normal heart muscle anatomy. And I'm going to talk a little about remodeling of the left ventricle. Here in the middle, you can see that this muscle has gotten very big. And this is like, it's had increased workload over time. It's really is working harder over time, so it's gotten bigger. So usually when your muscles are big, this is great, yay, it's better, but not for your heart for a couple of reasons. One of them is this is a lot more muscle, so your heart itself needs much more oxygen. So if you have restricted coronary arteries, if you have plaque buildup and not enough blood, you are going to get chest pain much quicker because you need more oxygen to keep this heart going. Look how big that muscle is. The other thing is it's stiffer. So usually your heart, when blood comes in, we say compliance, and your lungs have compliance too. They have just like a little bit of give. So the heart has like a little bit of give, lets the fluid come in, and then kind of snaps back and helps get it back out. So that's just a compliant. It's soft and malleable is what it is. When it's thicker like this, it's stiffer, so it doesn't doesn't accept the fluid as well. And also look at the size of this ventricle compared to normal. It's small. So when we have diastole, when it's filling, it can't take as much fluid. So even though it can contract really good, it's this big muscle, I can give a great contraction. There's not going to be as much blood in there to get it out. So you will have decreased cardiac output because you just don't have as much fluid in there as you can accept in this normal left ventricle. And this one here, the dilation, this is really big. And what happened here is over time, it just had so much fluid going in to increase preload over time, so much fluid that it has stretched out. Now, this left ventricle is really ineffective. When it contracts, it's very weak. You are going to have much lower cardiac output with this heart because it's remodeled into a way that it just can't contract as effectively as the normal heart. Okay, heart sounds. So when you listen to a heart, you should just hear lub-dub, and that's just the closing of the valves. So that doesn't, you don't have to remember exactly which ones they are, but it's lub-dub. That's a normal heart sound. Lub-dub, lub-dub, lub-dub. When you hear an abnormal heart sound, so an S3 is just you have too much fluid. So people have heart failure, and also when people who are pregnant who have more fluid temporarily might have an S3. And there's just so much fluid coming back at once that when it hits the ventricles, you can hear it. So it's like lub-dub, lub-dub. And then S4 is when your ventricles are stiff. Then when the atria contract during, they start filling and then atria contract, and you have a little extra kick to get more blood in the ventricles. When that happens, it hits the side of the walls. Normally, you don't hear that. You only hear the valves closing. You don't hear the fluid moving. But this is fluid moving. You can hear it hitting. And that's S4. The other sound that's not normal is a murmur. And again, it's the fluid. You're hearing it when you hit itself. So you know when you're like if you've been to the ocean or if you've seen the ocean on TV, when the waves come back and hit themselves, they make a whoosh sound. That's just what a murmur sounds like. There's different variations of it, and there are different locations depending on what's causing it. But basically, it's just that the fluid, which should just be quietly moving through your heart, you shouldn't be hearing the fluid. Um, Now it's like hitting itself. Maybe the valve is stenosed, or it's regurgitating, or there's something on the valve, or there's another anatomical problem where you can hear the fluid. It's turbulent, is what it's called, and it's hitting itself, and it makes this noise. So it's not super important that you remember exactly what these are. They're all a problem with, uh, you can hear the fluid for different reasons, but understanding that they are abnormal. So if you hear them, you hear something different. That is this a chronic thing? This has been documented. This is well known that this problem has, mitral regurg, and I'm hearing a murmur. That's okay. Use document. But if it's a new finding, you definitely would want to report it to the provider. Okay. And the some list of medications, if you can memorize like the drug classes, what the suffixes are, so you recognize the generic name when you see it, and just basically what they're going to do. So like ACE inhibitors, the suffix is pro, like lisinopril, it causes vasodilation, and it does that by inhibiting RAS. So if you just remember those few little pieces for all of the meds on here, then it's going to help you understand what situations we would use them in. So I really encourage you to take your time and memorize this slide. Okay, and that is it. I hope that's helpful. Please feel free to email me any questions if there's something that you're not understanding. I could definitely find an easier way to say it to you, okay? All right, thank you.